Hello and Assalamu alaikum all. I welcome you all on behalf of Pakistan Institute of Living and Learning, Sustainable Development Task Force Pakistan, and University of Manchester. The agenda of the day is we will start with recitation of some verses from Holy Quran. Then Mr. Riaz Fatehana will formally welcome the audience. Dr. Naseem will share some reflections from our last meeting. And then we have 7 presentations on different domains related to preconception and pregnancy. Then we will have a brief question answer session by Professor Zaul Haq. And then we will discuss way forward, where all panelists will talk about different aspects. I will now request Muhammad Umair to start the recitation of verses.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم الله يعلم ما تحمل كل أنثى وما تغيد الأرحام وما تزداد وكل شيء عنده بمقدار. Translation: Allah knows what every female carries and what the womb lose prematurely or exceed, and everything with him is by due measure. तर्जुमा: अल्लाह जानता है जो कुछ किसी मादा के पेट में है और पेट के सिकुड़ने और बढ़ने से भी वाकिफ है, और हर चीज़ का इसके यहाँ एक अंदाज़ा मुकर्रर है। सदक़ल्लाहुल अज़ीम।
Jazakallah. I will now request Mr. Riaz Fatehana. Mr. Riaz Fatehana is MNA convener SDGs Task Force. He is Member Parliament of Pakistan. He is psychologist, he is human rights activist, and he is Chairman Parliament Standing Committee of Law and Justice. Mr. Riaz Fatehana, if you can please formally open the session and welcome.
Assalamu alaikum and good morning. I hope Professor Naseem Chaudhary is there and all other participants, our psychiatrists and psychologists, civil society organizations, and human rights activists. So, if you remember, we were together in London last year in 2019. That was a wonderful event organized by you people, and I presented there a paper on mental health. Today, this is a pride for us that we all are together again, because state of mental health is very important in this country, especially post COVID-19, and even not post COVID, still situation is going on, and there is another threat that we may increase patients of COVID-19, especially when opposition is going to launch big processions and big gatherings. This is another threat, not to government, but even people of the country. Anyhow, so unfortunately, at present there is no mental health act at present level. I personally moved a private bill in the assembly, and that is on the agenda. Due to some unrest and bad coordination in between government and opposition, most legislation is not being going on. So I hope whenever this will be able to present and to vote and pass, we can see that now this mental health act at federal level. But this is good that Punjab and KPK province have mental health acts. Interestingly, they are now state of the art and up to right, but at least they have. During, if you remember, during a London session, there was a conversation on suicide and after effects. Previously in Pakistan, at present, our law is very outdated, and if somebody survive, then police is ready to capture him or her. So I also moved a bill in amendment that rather than to police arrest the person who is also ready to die, and he should be sent to jail or in prison or in police station. It will be better that he should be referred to a counseling center to give him psychological and social support and community support and family support. Anyhow, with passage of time, we hope due to your technical and moral and comprehensive support, Pakistan's parliament is working on this. Me, as you know, I'm professional psychologist, a human rights activist, and a member of parliament of Pakistan. This is my 6th term. I served as Minister for Education in Punjab one time, and chairing a National Parliamentary Task Force on Sustainable Development Goals. So again, goal number 3 is for good health, and we are at present on 134th position in the world. Unfortunately, from Millennium Development Goal to SDGs, every time we are mostly dependent on bureaucracy, and there is need to improve their commitment and efficiency and credibility, of course, and their quality and capacity. Anyhow, now I would like to conclude because in UK there are 7 a.m. I think you selected time when people are sleeping. Or I can see Professor, my friend Mr. Naseem. I think I don't know whether you were able to complete your sleep or not. Anyhow, again I congratulate that your Pakistan partner PILL and Professor Nusrat and Professor Naseem Chaudhry and Imran Basir Chaudhry. Everyone is working hard and collectively. Thank you again. We are ready and we are at your disposal. Pakistan's parliament, Pakistani politicians, Pakistani psychologists and psychiatrists are behind you. Thank you.
Thank you.
Thank you, sir. Thank you so much. It's a pleasure to have you here, and we always appreciate your support. Today's session will be jointly chaired by Professor Naseem Chaudhry. She is a consultant psychiatrist and Chief Executive Officer, Pakistan Institute of Living and Learning. And the session will be jointly led by Professor Ziaul Haq. Professor Ziaul Haq is Vice Chancellor at Khyber Medical College, and he is also Dean of Public Health Sciences. I will take the opportunity to briefly introduce all the panelists. You will hear them throughout the session in different discussion sections. Other than Mr. Riaz Fatehana, Dr. Subira Shams will also join us. We have Professor Runeza Niaz. Professor Runeza Niaz is Director, Psychiatric Clinic and Stress Research Center. We have Tracy Mills. She is midwife and senior lecturer at Liverpool School of Tropical Medicine. We have Dr. Christine Ferber. She is Directorate Lead for Midwifery at University of Manchester. We have Professor Shahida Batul. She's a professor at a Department of Psychology, Government College, University. We have Professor Tahir Khalili. He is Professor of Psychology at Islamic International University. We have Dr. Noreen Sahar. She is from Department of Anthropology. We have Dr. Paveen Ali. She is Senior Lecturer from University of Sheffield. We have Professor Sheila Naeem. She is Director at Institute of Nursing, Dow University. We have Mr. Asim Nawaz Abbasi. He is Chief Editor from Day Spring newspaper. We have Professor Farhad Jafri, he is Head of Community Health Sciences, Karachi Medical and Dental College. We have Dr. Aisha Minhas, she is Consultant Psychiatrist. We have Dr. Munazza Ubaid, she is Assistant Professor of Community Medicine at Dow University. Then we have Dr. Amjad Chaudhary, he is Consultant Psychiatrist at Fountain House. We have Dr. Sadia Asim, she is Research Fellow at University of Manchester. We have Farah Lunas, she is Global Coordinator for Global Mental Health and Cultural Psychiatry Research Group. And we have Ms. Shahida Kosar, she is working as Community Health Worker. And we have Mrs. Sana Farooq, she is Clinical Psychologist and she is expert by experience as well. I will now request Professor Naseem Chaudhary to share some reflection from our previous meeting that we had in March this year. Professor Naseem Chaudhary, over to you.
Thank you, Tayeba, and a very warm welcome again to our esteemed panelists. We've got a real mix, but I want to start with a big thank you to Mr. Riaz Fatehana, who's really leading this initiative from the front. He's championing it, he's supporting it, he started this, and he's been with us through this journey from the beginning. And I don't have words to thank him enough. So a big thank you to him. I just want to go back to early this year, March 2020. I think it was a day or two before the COVID really hit us and everything went into lockdown, where we first met in Islamabad for our all-parliamentary mental health summit. So for those of you who were not present on the day, I just want to briefly recap that we had a first meeting at the Pakistan Institute of Parliamentary Services, where we met as a group. And this group that's meeting today is the group that is working on preconception, pregnancy, and mental health. And then we had the official inaugural of the summit at the President House. It was hosted by the President of Pakistan, Honorable Dr. Arif Alvi. And as you can see in the pictures, that we had a fantastic audience from really influential stakeholders across the globe. We have been asked to develop National Mental Health Policy 2020-2030 for Pakistan and its implementation plan. We know that all United Nations countries signed to the SDGs, they recognize the SDGs, and Pakistan is the signatory as well. And Dr. Fatehana has already alluded that we're really not doing very good with achieving our SDG milestones. The work, the implementation plan, the strategy that we are developing will help Pakistan achieve its SDGs. There's enough strong evidence now to support that social factors influence mental health. Social adversities, poverty, natural disasters, difficult relationships, they all contribute not just to the prevalence, but to the severity of mental illnesses as well. As an organization, we work across the life course. So we've got a life course approach: preconception, pregnancy, postnatal, early childhood, young adults, working adults, and older adults. So we've taken a similar approach for our strategy and implementation plan as well. Can we have the next slide, please? So some of the themes, there was a very interesting discussion during our first meeting, and some of you who were there would know that we overran and really we had to rush to go to the President House. But some of the themes in terms of problems that were identified were around child mortality, healthcare budgets, and a lot of discussion went around the lack of evidence during the preconception period, lack of awareness. Early marriages, again, were a biggie, and it was very topical. We spoke a lot about the early marriages. Next slide, please. And again, we discussed solutions. It was around, we need to refocus on the cultural research needs, building the capacity of our members of government, involving the government officials in the initial meetings and in these implementation plans, scaling up parenting interventions, students, raising awareness of mental health in students was also discussed in quite a bit of length. Next, Tayyaba. So when we look at the evidence of social factors that influence mental health, I think the work that's been done by Lund et al. Is fantastic, as they've developed a conceptual framework of these social factors. And what they've done is they've aligned these with the different SDGs. Can we have the next slide, please? So they have divided this in 5 domains of social factors under demographic, economic, neighborhood, environmental, social, and cultural. And I like I said before, they've aligned them against relevant SDGs. Now, when we were doing this work, when we started with this work, we recognized that Lund has not used any SRs or any research evidence from Pakistan. So we started this initiative of evidence synthesis. So doing systematic reviews from research that's done in Pakistan so that we can understand these social determinants and its implications in the context of Pakistan. So what's going to happen next today is we have 5 different teams working on each of these domains as individual systematic reviews. So someone from the team will present, because this is just preliminary. We are continuing to work on it. And today is that they'll briefly present their findings so far. And then we'll have 7 minutes for each of these domains. And that's where we need our esteemed panelists to share their experience, their views, their thoughts. But keep in mind that we've only got 7 minutes. So a quick response. If people think that there isn't time, just put it down on the chat. And when we talk about in the end way forward, you will be hearing that this is not the end of our meetings. We'll have frequent email correspondences, and then we'll meet again March, April time. So I would request my colleague, Professor Hussain and Tayyaba, to please keep everybody on their toes, remind us about the time. Can we move to the next slide, please, Tayyaba? The next slide?
Ma'am, I think this was the last one.
Yeah, okay, thank you.
Thank you, Professor Naseem. I would now request Bilal if he can share a very brief video that we have for glimpses from the last meeting. Thank you, Bilal. We will now move to the 5 SR presentation that Professor Naseem has just mentioned. Our first presenter is Muhammad Umair Ehsan. He is Research Assistant at Pakistan Institute of Living and Learning, and he will share SR on demographic risk factors. Over to you, Umair.
Thank you, ma'am. Assalamu alaikum. Good morning to everyone. I am Umair Ehsan and I am Research Assistant at Pakistan Institute of Living and Learning. Today I am presenting systematic review related to demographic risk factors during preconception and pregnancy and how these factors are related to sustainable development goals. Next slide, please. So what are the demographic factors? These are characteristics of a population such as ethnicity, gender, sex, and age. These factors can act as both risk and protective factors, having association to Sustainable Development Goal 3 and 5, that mainly focuses on good well-being and gender equality. Next slide. Our focused review questions were the demographic risk and protective factors of mental health during preconception and pregnancy in Pakistani women. And secondly, what type of potential interventions are available to reduce maternal mental health disorders. We initially screened 650 articles, and from these 650, 34 articles were shortlisted. So moving on, our preliminary findings were that in a cross-sectional study with pregnant women, overall 49.7% were found depressed. Their mean age was 27.9 years and associated with factors identified were age between 31 and 35 years. Secondly, in 2 of the studies, women were recruited in their 3rd trimester, and it was found that persistent depression was significantly associated with having 5 or more children. Further, increasing age was found to be strongly associated with anxiety and depression. Next slide, please. So, and for prevalence of depression in different trimesters, most of the cases were found between 22 and 36 weeks of pregnancy. And finally, effect of antenatal depression on neonatal outcome in women were found to be poor diet intake, which had increased incidence of fetal growth retardation, low birth weight, poor mental and physical health of child, and breastfeeding cessation. These were the results which we get. Thank you.
Thank you, Mayor. Now it's a discussion session to discuss the overview of demographic factors.
Thank you, Tayeba. Can we have the pictures of all our panelists on? Yeah. I think it'll be nice if people can just raise their hand if they want to make a comment. But really from this older age, there was a study of younger age as well. And what struck me was that we were also wanting to look at whether there were any intervention studies done. And it seems there were none because Umair has not listed them. So again, is this something, and I'll probably first start with my colleagues from the UK, whether they have any thoughts or whether they're aware of any intervention work that has been done regarding gender or the demographic factors. So Christine, Tracy, anyone, do you want to make a comment on this?
Yes, Tracy.
Hi, Naseem. Yeah.
So that very interesting work. I think it's really important to identify the risk factors before. So obviously my area of interest and expertise is around the care that we provide for women who've had a stillbirth or a neonatal death. So they're a group who are at high risk of developing mental health issues. Your systematic review reflects the state of intervention evaluation. So I think in high income countries, we have developed interventions to support parents to some extent, but I think there's a real lack of evaluation.
Thank you, thank you. Anybody else with any thoughts, any suggestions? Because we're just starting on this. This review we'll continue with the review. Is there anything missing that needs to be added?
Can I just say, I'm not aware of any interventions. I did actually run a preconception clinic in the late 1980s, and that was one of the very first ones. I ran that at Stockport before I went into education, and there's been very little done since. And we are aware of a lot of lifestyle issues and the impact of gender, etc. But unless, I think it doesn't really get addressed clinically unless people have difficulties getting pregnant.
Can I make a comment, Naseem?
Yes, please.
One of the things we are trying to look at in these 5 different areas is aligned with Sustainable Development Goals, that in this section, if we focus on, say, demographics. So demographics, there are 2 findings which Omer presented. One, older age, and then younger age. So they're kind of conflicting findings. Half of the studies are saying older. So one of the things maybe looking at such studies in a bit more detail may be helpful. What are the other factors? Because one of the things which had come out in depression studies in general is when they talk about extended families and the role of in-laws, in one part of Pakistan, it was protective factor, while in the other part of Pakistan, it was a risk factor. And it was the other environmental circumstances where mothers and women had to go to work. In-laws were a protective factors. Where women were staying at home, were homemakers, that was a risk factor. So we maybe need to look at that in a bit more detail. I think the other work which Bill Gates and a foundation has been supporting is some kind of preventive work around early marriages, teenage pregnancies, that kind of work has been going on. Is any work, I'm sure there were at times, there were concerns within the UK as well. Tracy, yeah?
Yeah, so there have been, I think the context is very different. We had a major issue with high numbers of teenage pregnancies in the up until the last few years, really. So there was the teenage pregnancy strategy was introduced in the UK. I can't quite give you the date off the top of my head, but what I do know, so that was a sort of public health campaign with sort of multiple strands of intervention targeting different issues, but for a lot of girls in the UK it was unintended pregnancies through early sexual activity and not particularly early marriage, but that has been actually very successful. So there are probably elements of some of the public health messaging particularly, and I think some of that was around trying to encourage girls in the UK to think about what else they wanted apart from having a child very early in life. So I know some of that was very, and Christine probably could speak to some of that as well.
Yeah, that was sort of in the late 80s. the public health strategies around teenage pregnancy, and there was targeted interventions around the UK as well, like in Manchester and Stockport it was very high, and I mean it was more about well, it was capturing them when they were pregnant more, and then to stop them or prevent future pregnancies. And they included education. We had specialist midwifery roles and health visiting roles that were developed to support them as well. And that those strategies have been quite successful.
Thank you,
For
Christine.
teenagers.
Thank you. Farah, thank you. You've put in the chat a publication. Do you just want to briefly mention about it here?
Yeah,
I won't take too much time because of publication, but I've read it before, and it basically talks about the implementation of the UK's 10-year strategy targeting teenage pregnancy, and it has quite a lot of detail about different things that were done, and it's probably a good starting point when you're looking at how to maybe implement some of the strategies in Pakistan as well.
Thank you, Farah. So anybody else wanting to? Yeah.
I've got one more comment.
Yeah.
I think the other thing which Omer mentioned about in demographic is ethnicity. And I think that is, we did not find anything about, we have got different ethnic group across Pakistan. So there was not much about which ethnic group has like better outcomes or poorer outcomes. We can learn about maybe those cultural practices within those ethnic groups. So that may be another area to look at when you continue with your review, is has there been any such work and can we look at it?
I think Dr. Munazza wants to say something.
Yeah, Assalamualaikum. I just wanted to add, when Tracy mentioned saying that the issue of getting pregnant at an early age, the issue there is very different from what we have in Pakistan, because like, you know, there may be the only girl herself, or maybe the counterpart is related. But here, the whole family getting that child or the girl married is like, you know, involved. So we need to work on a total mindset here when we're talking about Pakistan or our like, you know, Southeast Asian countries, where the father and the mother and the grandparents and everybody is involved getting the girl married off at an early age. The fact itself that she's married or not married is not the thing. The thing is that she's being stressed by the whole family. So we need to work on the awareness of the whole community, not only just those girls or like, you know, the actual involved people, but the whole lot needs to be sort of made aware of the situation. That's what I wanted to comment.
We can take one final comment because
Dr. Noreen wants to say something. So very quickly, last comment. Thank you for reminding us.
As an anthropologist, I believe that, you know, I'm taking up on my respected colleagues that we need to focus more holistically on the research, because, you know, we are living in a collectivist culture. It's not just the couple or the girl, it's the, you know, the whole area around her, whole set of relationship, parents and everybody. So my suggestion is that we need to come up with a more holistic qualitative research that would be more appropriate to have the real picture of the phenomenon that we are looking for. Thank you.
Thank you, Dr. Noreen, for your comment. When we are at the end of the discussion, it will be useful to see what you suggest in terms of what else could we add. Thank you.
Thank you everyone for very insightful comments. I will now request Mohsin to share systematic review on economic determinants of mental health. Over to you, Mohsin.
Thank you, Tayyaba. My name is Mohsin. I am a health economist. in Pakistan Institute of Living and Learning. Today, I'm going to present the systematic review, and this review is based on the Sustainable Development Goals. And the title of the review is the Economic Determinants of Mental Disorders among Depressed Pregnant Women in Pakistan. Next, please. Okay. These 5 different Sustainable Development Goals comes under the economic domains, and this refers to the poverty. The second is hunger. The third is decent work and economic growth. It refers to the employment status of a person. The next is industry, innovation and infrastructure. This refers to the industrial transformation and revolution. The last is the reduced inequality in terms of monetary aspect. Next, please. These are the key economic factors that have a link with the mental health outcomes. And these economic factors could be a cause of to bring these mental health outcomes. These are the economic factors. This may include income insecurities, debts, assets, food insecurity, employment, housing, and so on. So these factors would be a leading cause towards the mental health in terms of economic perspective. And these mental health outcomes are depression, anxiety, substance abuse, and psychosis, so on and so forth. Next, please. Okay. This is a Prisma diagram. Getting out of the search, this all we have got the 425 from the automated search, and we have got 1583 from the manual search from the different databases, electronic databases. So we have selected after the screening of title and the abstract, we have got the 4 studies that we have included our systematic review. Next, please. These are the preliminary findings of those 4 studies. 2 findings related to the interventions, possible interventions available in the local settings, and the 2 findings related to the cost that have been made to calculation of the cost. The first findings relate to the about the early identification of the parents who are at risk would be bring out to reducing the mental health symptoms, especially in the prenatal period. Another findings reflects that we are addressing those social causes and the realization of the human rights that will bring the woman towards the economic participation in the household, and this is the first step reducing the antenatal depression. The next third and fourth evidence shows the cost of the attempts has been made to calculation of the cost. The third evidence shows that it's in the UK setting that had been attempt. The total cost is about £74,000 in the prenatal period, and the last evidence shows that we have the cost near about 1,000 for the monthly expenditure if someone have a perinatal disorder, and near about 3,800 for the other costs included. So more or less near about 4,800 Pakistani rupees would be the total cost of antenatal period. Next, please. These are the possible potential intervention that is present in the local settings. Number 1 is a cash transfer or the basic income grants to the local population. Next is the employment. This is the employment status for the lower level and middle level. These both of them have a high impact on the people that lives in the local settings. And the last is the reduction of the income inequality. It does not put a direct impact to the betterment and prosperity of the people, but it put an indirect impact on the some aspect of the macroeconomics level. Next, please. And this is the end of my presentation. Thank you very much.
Thank you, Mohsin. I would now request Dr. Nasir Iqbal if he can kindly chair this discussion session for economic factors.
Thank you so much for giving me this opportunity to look into this. So before I ask everybody to have their own comments, let's start with some basic discussion on what are the economic implication of this health as well, especially the mental health and also for the women. So the Mohsen rightly explained the underlying factor that it all relates with SDGs, and especially poverty, inequality, social exclusion, climate change, education. All these are the key factors that explain the health part of not only the mental health, but also the physical part of the health. So over the last a couple of years, I am also working on this, the social dimension of this health. And I did some initial analysis at the very beginning of a couple of years back about the health disparities across the region. So it is evident that the poor areas, especially interior Sindh, Balochistan, and the KPK, and also the South Punjab, have a high prevalence of the low health, and as compared to the central Punjab and the urban area of the Sindh. So this again linked with the social part as well as the SDGs. So before I leave this, I have a few suggestions to improve this whole discussion, because this is a well-known and a documented phenomenon that these social issues as well as economic issues like poverty, inequality are the key factor in determining the mental health, especially if we look at the COVID situation. When there is a safe employment, the people have less tension, less mental stress, and they are more comfortable. Like if you are employed in a regular sector, you have a regular job in the government sector, you are less worried. But if you have informal employment and you also fall in the lower segment of the society, then it will increase the stress. And you might have heard that Fatehana Sahib is there, the government basically advocating the same concept. If we leave these the poor people in this mess, it will create not only the physical health problem, but also the mental stress, and it's very evident. So giving this, it's the very important to see how different intervention, as one or two suggested by the Mohsen, like the cash intervention as well as the employment intervention, how these interventions channelize the negative consequences of poverty and hunger and also social exclusion in terms of looking into the mental health. And if he's really interested to expand this review, he should have to look into how these efforts mediate the negative consequences or the negative nexus between poverty and hunger and with the mental health. So the mediating effect is very important. And you should also explore other dimensions, like the Zakat has a well-known network throughout the country, and also the NGOs, those are supporting this, the poor people, they also have a very well network. And also, most importantly, when we are looking into the economic determinant, we should look ahead to the informal social networking of the people. Because Dr. Nusrat also knows that the informal sector, especially in the rural area, plays very key role in terms of supporting these people, those are in danger and in out of in crisis mode. So you should also have one section in these informal sections. So with these few suggestions, I'll stop here. Now that other people can also have, if they have a comment, they can put it on it.
Can I make a comment? Yes. Thank you very much, Dr. Nasir. I think one of the things which I noticed was a lack of research from Pakistan. The last study, which was in Pak Rupees by Mohsen, were published in year 2000. You know, like 20 years ago. That is not something we should be basing our further work and our recommendation and the way forward. I think looking at more recent relevant research of today, and that is something is that probably we do not have enough people working in health economics in general and mental health economics in particular. The other point I wanted to make was, the third sector and the informal. I think probably Pakistan is one of the, highest in the world about per capita contribution to philanthropy and charity. That also somebody needs to work on it and put those costs together and look at that is what our strength is, but maybe how well we can use. The other thing which the earlier was, whatever we are doing, the women at least have a depression rates of up to 47, 45%, at least in some areas. So looking at the huge costs of depression on one side and limited research is how do we try and reduce this academic gap would be hugely important.
Yeah, I think it's a valid point. Like the informal sector, if like a few months back, there was one study. These were comparing on the philanthropic part of this UK with in comparison with Pakistan. So he basically looked at the Pakistani community working in the UK. So this is a very big contribution in informally and formally. So it also linked with the mental health basically is the outcome of some sort of stress. It could be like economic stress, it could be like emotional stress, whatever it is. You people know better than me because I'm the economist, not the health practitioner. But the ultimately the underlying factor would be the economics in my opinion. Even if it is a physical health, even it's a medical health, mental health, the underlying factor basically is the economic stress. So the Muslim should look into these dimensions, how these like channelize this whole exercise. The idea is not only looking into the impact, but how they contribute to this whole stuff. Because if we are really looking for some sort of policy solution, then we should have to look into how these concepts basically facilitate this whole process.
Thank you. Do you want to say something? Yes, please.
I think we can learn from outside Pakistan also, because we have got limited research in our own country. So there's been work done, I'm sure about in the UK, about the informal care which is offered by a family mainly to people with severe mental illness, and they have put costs to it and how much they are contributing towards NHS. So I think those kind of work which we can learn. And the other is there's also been work done in Uganda about cash transfers and non-conditional cash transfers. So that kind of work is again we need to look at if we are able to do such studies in Pakistan.
I think there are also literature available on this intimate partner violence, how this cash conditional as well as unconditional cash transfer like have an impact on this IPV. So you can also look into these issues. So that probably will help you in terms of. Recently, I'm conducting a survey on the illegal migrant in various parts of the world, because this covered on the other, though the formal migrant worker have some space to get physical as well as like the health support from the relevant government, but the illegal migrant faces a lot of problem in terms of either to accommodate themselves in the destination country and also to support their people back in Pakistan. So I'm trying to look how this COVID basically have an impact on their economic as well as health part. So once the study is there, I'll be happy to share the finding on the issue.
Thank you, Dr. Nasir. We will now move to our next presentation, that is about neighborhood factors. I would request Aisha Halik to present. Over to you, Aisha. Aisha, are you there?
Assalamu alaikum. Can you hear me?
Yes.
Thank you, Ms. Taiba. Assalamu alaikum. My name is Aisha Halik. I am working as a research associate at Pakistan Institute of Living and Learning. Today, I am going to present a systematic review of neighborhood risk factors and their associations with maternal mental health during preconception and pregnancy in Pakistani women and how they are related to sustainable development goals. By neighborhood domain, we mean the characteristics of any area that act as a risk factor or protective factor for mental health. These characteristics are strongly associated with sustainable development goals, particularly with goal number 3, good health and well-being, 6, clean water and sanitation, goal 7, affordable and clean energy, goal 11, sustainable cities and communities, and sustainable development goal number 12, responsible for the consumption and production. The main review questions for this systematic review was focusing on the neighborhood risk factors and the protective factors for maternal mental health during the preconception and pregnancy in Pakistani women, whereas the focus of the second question was to identify the potential interventions on neighborhood aspects that are beneficial to reduce mental health disorders during preconception and pregnancy in these women. Initially, we found 282 articles, and we ended up with the 26 articles that were included in the systematic review. We extracted 2 major themes from the initial findings of the systematic review, that are living in under-resourced area or the lack of facilities and deprivation of resources like spousal unemployment, poor family, and lack of social support were strongly related to maternal mental health issues like depression and anxiety. Thank you so much. We soon will be able to share full results with you all. Thank you.
Thank you, Aisha. I would now request Professor Zaul Haq if he can kindly chair the discussion session on neighborhood factors.
Thank you very much for inviting in us. I think this is a very important area, especially in this part of the world. It is something very important, and as Professor Nusrat found that we need more research on it, and I think this is something we need to work more on it, especially in any chronic disease. This is needed, but especially in mental health, this is more important. So I invite all the panelists to have their comments.
I think this.
Should I start with the discussion?
Yes, go ahead, Dr. Shahida.
Thank you very much. It's very interesting neighborhood protective risk factor. This is very interesting topic, and I was thinking about what neighborhood exactly means by this researcher. First of all, I would like to know how many researches from Pakistan were included in this systematic review, because we, as researcher, we know that there are very few researches which have been carried out on the health of maternal health and health of women during pregnancy and due to child loss before delivery. I did cross-culture study that was based on Pakistani women and women in the UK. And the one thing that I found that was healthcare system facility. Because in Pakistan, women, they were not very much satisfied with the healthcare system of Pakistan. They believe that our problems, our psychological problems especially, they don't give any importance to us as a human being. They treat us as a machine, and when we go to the health professionals, they don't believe that we have any emotional or psychological problem. And what I found in the UK, that was one different factor, that was women were satisfied with the healthcare system regarding medical care, but at the same time they were not satisfied with the psychological care and psychiatric rehabilitation of women who are suffering from infertility issue and child loss and things like that. So I think when we talk about Pakistan, in Pakistan, we have to emphasize on healthcare system of Pakistan, and we should incorporate the suggestion and recommendations of the researchers who have carried out researches not only in Pakistan but cross-cultural studies that compare the system, psychosocial system, economic disparities, and healthcare system of countries which are developed and which claim that they are providing all type of facilities to women.
Yes, this is something very important points. And the research area, I really like the research area, and it's something we need to work more. Any other comment on this?
Just a comment about your work, Professor. You have done a very large survey in Khyber Pakhtunkhwa, and you have also looked at women and their mental health in that. Have there been any findings from the large survey you have done in Khyber Pakhtunkhwa?
Yeah, I think this is, we published the first protocol and 2 papers, and now I requested you as well to help us in analyzing this. And that very important data is across the province, 22,000 household. And let me share 2 other good news which is related to it. One is that we got funding from the Department of Health that we will do the same large survey across the KP in Pata, and we will repeat it every 6 months. So I could, that is mainly on the maternal and child health and immunization. But I came out of the meeting before starting this one that we will add something for the mental health. So I will need your guidance in that. And that will be repeated every 6 months for at least 2-3 years. We secure funding for that. So that is number one. And the second is that you must have heard about a fountain house building in Peshawar. And that is by the Government of Health. So I pleaded the case, and Alhamdulillah, now they said that we will give this to Khyber Medical University as constituent. So I developed something that we will make it one center of the excellence, and that will be a very defined, it was a defining moment. So I just developed that this is a fountain house that will be center of excellence, and inshallah it will be the hub of these researches. And the more I interact with the mental health people, the more I fall in love with you guys and the way you work. But this is the century of the mental health, so it's a lot of opportunity and also a lot of work we need to do.
Inshallah. And congratulations, brilliant work, Professor, as usual.
Yeah, so this is a 250-bed hospital, and we are converting it into a center of excellence for the mental health and behavioral science. And a lot of help will be needed from this forum and you as a mentor, and also from your organization, the BIL, to work closely with us.
Yeah. Can I make one comment on coming back to the neighborhoods? I think Dr. Nasir also mentioned about that in a number of regions, the communities are really providing care and looking after and support. So that support, social capital and that support and neighborhoods, I think it's important that we are able to work on it and look at how much we can build on those strengths which are already there in our community and work through that. We are, we have limited resources. There are limited resources in a country like UK as well. So the importance of neighborhood is being recognized more and more. Within the neighborhoods, people are also looking at green spaces. The whole advantage of having more green spaces is being worked on. People are also looking at how the other facilities are available for youth and young people to be able to engage in healthier activities. So that kind of work, I think we need to look at in Pakistan. And again, I was looking at one of the household surveys, and they did look at, I think it's the Pakistan Panel Household Survey, that there was somebody who would, after the survey, go out in the community and make observation about what is available. Are there schools available? Is there water available in that neighborhood? And those. So maybe looking at what is already has been completed in Pakistan with regard to research, we also need to look at that. Maybe some of the grey literature would be helpful.
Yes. Yes.
So just say in the UK, within neighbourhoods, this concept of social capital and utilising social networks has been very successful over the last 20 years in supporting mental health in women, particularly in the UK, particularly in the postnatal period. That's the time when they often feel quite isolated. And obviously, in this current climate, the promotion of online social networks, that's very topical, very popular as well as a means of peer support.
Tracy, you were saying something?
I was just wondering, so this is a question really for my colleagues in Pakistan, whether there had been any work done around promotion of physical activity. So group physical activity, there's a lot of more interest in that as a potential strategy. So in the UK, there are quite a lot of campaigns around trying particularly to get women to be more physically active. And I know there are probably, there's probably some of the same gender barriers in Pakistan, but I was just wondering whether there was anything done in that area.
In society, which the socioeconomic status, talk about the rural area, there are more physical activity, the female working in the farms, in the fields. But in the city, I think there are less opportunity in the cities for them, because it's congested and very few parks, and the female security is also an issue. So yeah, this is important point we pointed out. But what I noticed that in rural there are more opportunities than in urban.
Thank you, Professor Ziaul Haq, and thank you everyone who contributed to the discussion. We will now move to our next presenter, Amreen Khan. Amreen Khan will talk about environmental factors that are related to mental health during this period. Over to you, Amreen.
Thank you, Sayeba. I'm Amreen Khan, and I'm a research assistant at Pakistan Institute of Living and Learning. Today, I'm going to present about the environmental risk factors of maternal mental health during pregnancy and preconception in Pakistani women and sustainable developmental goals. Next slide, please. I will briefly explain you about the environmental factors. These are the events that are defined as serious disruption of community functioning that exceeds the ability of the community to cope with by use of its own resources. It may include the natural hazards like earthquake, any armed conflict area, or any ecosystem hazard caused by increased population of rain. Out of 17 sustainable development goals, two goals are relevant to it. That is goal number 13, which indicate about the climate change action, and goal number 16, which indicate about peace, justice, and strong institutions. The most common outcomes have related to these environmental factors. That is, mental health outcomes are PTSD, that is post-traumatic stress disorder, depression, and anxiety disorders. Next slide. The review question of our review is, what are the factors or protective factors of mental health? By using the structured search strategy and through electronic databases, we got 53 articles and finalized three articles in the end. This article is an ongoing review, and we will surely include the contribution of Professor Unaiza and Professor Abdul Rahman and Professor Bhutta. The preliminary findings of this research is, first of all, the association of natural disaster is strong with poor mental health. Second finding indicate that women who are living in a post-conflict area are at high risk of depression compared to the general population. And moving toward the end, the risk of emotional behavior and increased is due to increased population for the women who are living in low resource areas. This is from my side. Thank you so much.
Thank you, Ambreen. I will now request again Professor Ziaul Haq if he can kindly facilitate the discussion on environmental factors related to mental health.
Yeah, I think this is also related to the first study, and if this is a start initial, these are very important areas which are really untouched. So I think this is again very important area, a research area that we need further research, and very important to the mental health if holistic approach. So I request other panelists to have their points.
Professor Unaiza wanted to comment. You're on mute.
Ma'am, you are mute.
I just briefly wanted to say something about Karachi. We are talking of all the provinces, especially it's very interesting that the Khyber Pakhtunkhwa has lots of very good researchers, and interestingly, our PM Imran Khan also started the health card from there. But I think in Khyber Pakhtunkhwa, I would request, I mean, obviously you are doing this, working on the mental health issues. So please make sure that in the health card, the mental health care is also included. Now, Karachi, amazingly, is a large cosmopolitan city. And as far as environment is concerned, you'd be amazed. We right now are going through a crisis of not only COVID, but the sanitation, the water crisis, the cleaning thing, the rubbish is all, I mean, there's a lot of conflict between the different authorities, the local authorities and the Sindh government and the other, etc., etc. So there are lots of problems, environmental factors there. And please remember that in this large city, like any other large city like New York or London, there are areas of fairly low income people, especially the labor class. They're not really slums, I would say, but there are areas where they're poor, the roads are not good, the environment is very, very claustrophobic. They live in small rooms or very small houses. And women, as you know, in our part of the world have the last say in anything as far as their health is concerned, as far as their nutrition is concerned. And nutrition is the main problem. Secondly, of course, health. And health is the last thing as far as women are concerned. Only when there's a crisis, then everybody wakes up and then they're taken to emergency. It's usually late, or you know, that's the reason why we have a high mortality, maternal mortality and child mortality. So I think I would request Nusrat to actually tap different areas in Karachi. That would be very interesting, because I am part of the bill, but you see in the upper classes, even in the middle classes in Nazimabad, etc., I mean, there is no support for women. Though women are in affluent classes, affluent areas, and they do go to the private hospitals, and they can just about, middle class can just about handle the expenses of healthcare. But even in upper class, where they can handle expenses of healthcare, mental health care is the last thing in their mind. And when they come, believe me, They come in crisis, they come to my clinic because I'm into women's mental health. They never come for follow-ups. Very few women will come for follow-ups. So I think we are doing, the Pakistan Psychiatric Society is doing, the Pakistan Association of Mental Health is doing a lot of awareness. We have started, as you know, for some time, section on women's mental health, but it hasn't been very active because there are not many people. But I think through the platform of PIL, we can work, and we can also have, I would suggest, another project or what do you call, a part of this project which is going on, that we include the large cities also and give a sample of that and what can be done. We do not have a health card yet, but hopefully Imran Khan or the Sindh, it also depends on a very stubborn Sindh government, if they agree, but we do have a Sindh Mental Health Act, which is a very good news. And this gentleman who came for all the mental health day functions, he was very keen, and we did talk about attaching this mental health care, this Sindh mental health care facilities to the community also. So, but we do not have national health scheme. I think only if there's a national health scheme, or then only these things will work. Survey is excellent, but I think in that you could mention that I think in Karachi, places like Karachi, there should be, I think the poor are poor, everybody is there. They're obviously not getting the best treatment, but believe me, the middle and the upper class women are suffering like anything. So I'm actually representing them, and we have a problem of in-laws, especially mother-in-laws or the sister-in-laws. They become different when they are the mother-in-law, sister-in-law, and different when they have daughters and themselves are concerned. So I think this more of awareness, more of a survey should be done, and then we can present the results to them. And go to different, and also involve the gynecologists and pediatricians. Thank you.
Thank you.
Can I make a point?
Yes, please.
Professor Ineza, thank you so much. And I totally endorse your viewpoint, because working in a cosmopolitan, affluent area of Karachi, you think that all the mental health problems are sort of focused in our poverty-stricken, deprived areas, but we see a different set of problems. They might be living in 10-bedroom houses, but they are severely depressed, and they have a different set of issues that contributes to their mental health. And when we were talking about neighborhood, I was thinking, have we ever sort of looked at people who are living in these very affluent societies? I mean, I'm not sure of any work, I've not looked into it, but say people living in Beverly Hills, and I'm sure they'll have their own set of mental health issues and problems, but we're not aware of it, or we don't tap into it.
Yeah. And you see, the most interesting thing about Karachi, whether it is, but mostly the middle and I think starting from all classes, the lower middle class, the middle income, and the higher income classes, there is a lot of shuffling. People are not permanent neighbors, you see, or they do not stay permanently in a place. They either move abroad, or they're moving to and fro to Pakistan, they come on holidays, and then lots of people migrate from one city to another. This is very common. They've gone to Saudi Arabia, they've gone to different countries. Karachi is a place, it's like a, I don't know, special for upper class. It's like a 5-star hotel. People come and go, visit. So there's no permanent neighborhood. This is the saddest part of Karachi, I think, that we do not have a permanent neighborhood. We live in areas, I mean, I live in one of the nicest area, that's a Defense Housing Society, the oldest space, and we keep to have change, and the neighbors keep changing. They go away, the elderly pass, the youngsters, the younger children, etc. They're married, they come and go, or they rent the places. And the rented people, they keep moving. Obviously, they keep going to different neighborhoods. So this is what I wanted to say, that I don't know, we'll have to survey and then somehow devise some sort of a system where these women can be supported.
Professor Zia, can I make a comment?
Yes, please.
Yes. I think coming back to the environment and and coming to Karachi, we had these floods in Karachi, and a lot to do was the way the waste disposal was. So that was a big contributor to the floods. I think we also need to think about how much we can take personal responsibility in the city as citizens, and what can mental health professionals work along with the community to take that personal responsibility. And we have got examples like the Orangi pilot project. It was, one of the world's most quoted projects. How we have moved from that Orangi project to where Orangi is going through very difficult time. So we need to also look at what kind of behavior change is required. We look at those needs, but how do we empower the community and look at that the certain areas, certain communities, because it's not only about the money, because you mentioned about the high income areas in Karachi. I think they were as troubled with the current floods and rains than the low income areas. So those bits of looking at how we can work with the wider community, but look at our own contribution as well as citizens and work through that. And I personally think there's a lot to do with our personal responsibilities in the sense of, if we look at the waste disposal, the general attitude of most of us is that, we would throw the plastic bags outside our walls. I know a street in Defense, and there was just a empty plot right across, wonderful houses, and people from the neighborhood would come and throw all that garbage in. So I think it's about personal responsibility also, Professor Uneza, and about looking at, but we need people like yourself to look at how do we do that? What role can we play? Because the government would continue to have limited resources for some years to come. And how can we work along?
Professor Nusrat, you must have read in the papers, the local community is very, very active. I would say when this flood, this monsoon rain came, they were really a disaster this time. So many basements and so many houses in phase 5, 7, 8, which is one of the nice poshest area, they were totally destroyed. And crores of, there were the commercial areas, the furniture, the electronics, etc., were totally destroyed and devastated the whole thing. People did their best, but the problem is the initial planning wasn't correct. They were not, the sanitation system wasn't correct. And the garbage conflict has been going on between different authorities in Karachi. And local people, I agree, what they do is they throw it in that one dump, big dump where the garbage should be dumped. But the main garbage has to be picked up. And so the pickup was delayed. Now, we can't normally go to, and there is no area where anybody knows, and everything is under control. Local people are dependent on the authorities, say the DHA, the Clifton Health Authority, etc., etc., and they don't do their work. And there's so much red tape. I don't know how it will happen. It's become such a puzzle. And we are all fed up. The stage came, we are all fed up. So I think, I don't know, the Prime Minister came, there was so much money was given, but then it wasn't given to the local government because there was so much corruption. It is an exemplary situation in our part of the world. But I think even in Brazil and in the South America, it is something like that. But there somehow the authorities like the Clifton Board or the DHA, they are passing on the buck to each other. So, I mean, it's some sort of a magical thing has to be done, because there's so many strong people all saying that you do it, or I'll do it, and that person is not prepared to relinquish his work, which he's in doing properly. So I think there is a problem, but it's not for researchers like us to get into it. But yes, we can do surveys and find, give them solutions. But I think we are hand-tied. Our hands are tied because we have very little time, and whenever we have time, we can only protest and complain. So the authorities, the people concerned, the so-called elected people, the housing societies, they have to take care of it. The sanitation and water, for example. There is a lot of water in Karachi, but the water mafia has taken over, and we buy tankers every day. So it's a catch-22 position, but I think we should leave that. But I just wanted to say we should do surveys and give them some statistics, not necessarily to everybody in Karachi. And then maybe we should change the whole system. But it's going to take long, and it has come to I think we are up to our eyeballs with all this thing. But it's a difficult thing.
Thank you, Professor Uneza Niaz. We'll have time in the end for discussions where
I just wanted to say the plight of Karachi psychiatrists and the so-called social society. We do our best, we complain, we are in newspapers, we are on TV, but nothing happens. That's what I wanted to say, and we should find as researchers. Yeah.
Thank you.
Yeah.
Thank you, Professor Uneza and all the panelists. We will now move to our final presentation on social and cultural risk factor. I will request Rabia Sitar to present. Over to you, Rabia.
Thank you, Sayyaba. I'm Rabia Sitar, Research Associate at PEL. Today I'm presenting a systematic review on socio-cultural risk factors of maternal mental health during pregnancy and preconception in Pakistan, and how these are related to Sustainable Development Goals. Socio-cultural aspects are ways in which the organization of society, social interaction, and relationship act as a risk factor and protective factor of mental illness, and these are associated with education, social cohesion, and other related determinants that are related to Goal 3 SDG, which is which is quality education, and ensure healthy lives and promote well-being for at all ages, which is Goal 3, good health and well-being. So our review questions are: what is the socio-cultural risk or protective factors of mental health during preconception and pregnancy in Pakistan, and what type of potential interventions are focusing on social and cultural aspects and are beneficial in reducing mental health problems during preconception and pregnancy. So we initially screened 274 articles, and at the end we have shortlisted 19 articles that are related to socio-cultural component. Preliminary findings shows that psychosocial correlates of perinatal depressions are less social support, uneducated women, rural background, and history of harassment in pregnant women. Moreover, we have found that extended family, past history of psychiatric problems, miscarriages, unplanned pregnancy, stillbirth, and other related complications in previous pregnancies are highly related to perinatal depression, and these women are also suffering from stressful life events. Next, please. Antenatal depression and its impact on child health was also investigated, and it was found that in rural community, infants of depressed women had lower birth weight, and poor dietary intake had increased incidence of fetal growth retardation and preterm birth. And exposure to violence and safety issues are also related to perinatal depression, including physical, psychological, and sexual abuse. And furthermore, safety issues such as fear of childbirth, separation from husband, conflicts with family and in-laws, history of housing, and marital status are also strongly related with perinatal depression. Next, please. We have found some interventions which was particularly related to psychosocial component. So we have found that Psychological interventions such as CBT delivered by community health workers are effective in rural communities of Pakistan. Thank you. Thank you, Ms. Tayyiba.
Thank you, Rabia. I would now request Professor Naseem Chaudhary if she can kindly chair the discussion for social cultural discussion.
Thank you. I mean, so far we've been having fascinating discussions about all our domain, but I think because I have a personal interest, this trumps it all. The social cultural factors, the relationship issues. I'm surprised that this is something that I would have expected more work. So maybe we need to go back and look at the grey literature, because I would have thought that we'll have more than 19 shortlisted studies, and more so on the intervention side, that just 3 studies on an intervention and just on CBT. But like, this is just a start. We are working on it. I'm hoping that our numbers will increase and we'll have more research evidence to show. But this is very, very huge in terms of the different areas it covers. And I'm very interested to hear what our panelists have to say. We've got with us a practicing psychologist who is an expert by experience as well, whether Sana is happy to share some of her thoughts, because she sees people, she sees a lot of people who present to her with these difficulties and her own experiences. Sana, if you're there, would you be happy to just share your 2 thoughts on this topic?
Yeah, I would like to, first of all, I would like to mention the points which were earlier discussed in our discussion. It was about the perception of social support, or the available support for the upper middle class and lower middle class. So I feel that both of the classes are facing same level of difficulties, but they're unable to, if we talk about upper socioeconomic class, so they are unable to express their problems which they are facing in their cultural contacts are a bit different from if we talk about the rural areas. So difficulties are same, but the outlet which they want to express their emotions, I feel they lack that. And the other point is they feel that I feel that they would also lack understanding in their relationships. Like if we talk about the in-laws, if we talk about the marital relationships they have with their spouses, in those particular aspects of their life, they also find it difficult to express their genuine feelings. So these are main, I feel, difficulties they are facing, and this leads them towards sometimes anxiety, sometimes depression. And again, when they seek help, they also face difficulties in attitudes toward help-seeking behavior. Sometimes they got criticized by their surroundings, the in-laws, the families, the extended families. So they again feel a bit shy or reluctant to accept the help. And again, the point which Professor Nazaniaz mentioned, that we are unable to take personal responsibility. Professor Nusrat mentioned that we should take some personal responsibility to make a change. So if I can relate with it with my clinical practice, people are reluctant to take responsibility to change their life. They usually blame them, the surroundings, the system, the people around them. So this is very important. We should take some personal responsibility to make some change in our life. First of all, we need to make some changes in our own perceptions of what we can do for others around us, how we can support them. The minimum we can do is we can attentively listen to someone's problem and try to understand what they're trying to say, and we can empathize with them. So this is my views about this issue.
Thank you very much. Before I sort of move on to the other panelists, I just wondered whether amongst our panelists, there'll be somebody who's willing to talk about, because from a clinical perspective, we see young women coming with severe anxiety and depression. And this is because they don't want to either conceive that early or they have got young children, but there is no concept of contraception within the family. And they're kind of, in some way, forced to have more children, and there's nothing they can do about it. So I don't know, I'll move to Shaila Naeem because of her working as a head of a department in the nursing university at Dow. Shaila, would you have any views from your experience in terms of how big is that issue for our young women?
Thank you, Dr. Naseem, for giving me this opportunity. I'll second your point over here. In our community, in most majority of the women are not allowed to use their family planning procedures. All the in-laws and the husband, they demand they should have babies every year. They have the babies every year because in jo gaon ke log hain, in the fields, they think their children will, when they will grow, they will be an earning partner for them, because homemaids, females, and they are working in houses, or jo boys and they are working in the fields. So the parents think they need to have more children. We need to give them the awareness or education sessions for them to have use the family planning, because the females, they go serious depressions about related to their health and related to the unemployment of their spouses also. There is a great need. We should work on this issue, and related to the family planning also, related to the mental health. Thank you.
Thank you, Shaila. I'll open it to the panelists. Please, any comments? Any?
I just wanted to say that you mentioned about awareness, etc., etc. Main thing is that the certain views and certain cultural beliefs are so strongly embedded in our society, which I think will take a long time. Now, for instance, lately, I was very upset by two incidences. One was, there was a program on one of the local channels about a very nice young doctor, very smart, like, I mean, I wouldn't say we are smart, but, competent, typical, etc., etc., but a perfect young lady, educated. She was married to a pilot or somebody, and unfortunately, when the whole family went for a dinner or something, and she was kidnapped. And obviously, she was gang raped. And the story is on the TV, and it was so pathetic. That girl was beaten right and left. I mean, all the time, her head was, that man and the mother-in-law was awful. The parents and the in-laws did not support her. They asked her not to work. They locked up her in a room. So this is happening in our society. In the lower classes, nobody can dare to help the woman. A woman came with postpartum psychosis about 2 years ago, and she was really short, and she had cesarean section, etc., etc. She wasn't happy with the in-laws. And I did say that if you have a second baby, again, she had a girl, and they wanted a boy. I said maximum one more child you could try. But of course, without even, she disappeared. She didn't have treatment. She came with the second baby. Again, she had a cesarean section, very bad postpartum psychosis again. And it went on and on. It's going on for now 8 years. And the father and the mother, they're all upper class. They're very upset. And they keep on stopping treatment. And they always say, why isn't she treated? She's been to the best doctors, but she doesn't follow treatment. What I'm saying is these are the things, beliefs, which are, in the mental health awareness and this thing about producing children. And just now, Shaila said about having boys because they work on the fields. Believe me, even in the farmers, the sons run away to cities, they migrate to Karachi. They may become a driver, but they will not work on father's land most of the time. That's why I think in so many ways, Pakistan is suffering agricultural level also, because agriculture isn't given that much importance. The others, even on an affluent society, the sons educate, they go abroad, they may either marry and not come back, or marry a local lady there, get a nationality and never come back. So I think it's not the question of having sons to help the family. It is a traditional view, and I think it has to change. Because I've worked in England and America, nobody really is, or no woman or in-law or anybody is bothered about a son or a girl. as long as it's a healthy baby and and a useful citizen. So I think this will take a long time. But what I wanted to say, just one thing quickly. Now, for example, this doctor on the television program. Now, her mother wasn't supporting, her father wasn't supporting. They stopped her from going. Now, if there was a good hostel or some place where this woman could go, she was a doctor, she could work and live independently. But there wasn't anything. She went out on the street, she was roaming, and then, again somebody came, she was already had been raped and all, so she had to go back to her in-laws because mother wouldn't have it. However, and then they commit suicide. So I would say that I think in research, we should also recommend these things and try and work at these inherent beliefs which are so rigid and which haven't gone, you see, unfortunately.
Thank you, Dr. Unaiza. We'll take a comment from Christine. Christine, I think you were talking about in your chat about birth spacing.
Yeah, when women get pregnant quickly after they've just had one child, the body doesn't have chance to recover after the previous pregnancy. So birth spacing might be an opportunity to look at. Obviously, this is going to bring in education around family planning, but it enables people to have spaces between pregnancies so the body can recover physically and mentally. And that's, really, that's quite an important public health strategy that's been used globally, really.
Thank you, Christine. Taiba, how are we for time? Because this is a very important, useful discussion, but I wonder whether can we sort of use this discussion for when we are talking about way forward in the end, or we've time now?
We have to open the way forward discussion now. We had 5 minutes for question answer session, but I would request everyone, if they have any question, they put in the chat and we will definitely come back to the questions.
So are we moving on to the
I want to comment on this psychosocial determinants of mental health. When we look at psychosocial determinants, the very first thing that comes in our mind as a researcher or as a psychologist, that is social support. But unfortunately, this is no doubt this is very positive point, but we forget in collectivistic societies like Pakistan, if we look at the experiences of women who are going through sufferings during pregnancy and child loss, the one thing that they bear is social intrusion, social inquisition, social privacy breach of these women, because most of the women, they feel that this is our personal issue and we don't want other people to intrude into our privacy, and they have no right to give us suggestions, and they have no right to comment on our state of pregnancy or loss. So this is one thing that I found in the UK, that people were very happy with the social context in which they were living. They believe that this is our personal issue, this is our private life, and we don't let other people to intrude in our private life, and we are happy with it that me and my husband or my partner, they are dealing with this issue. But in Pakistan, this is a kind of trauma for women who are suffering from pregnancy issues, that people around them, they feel that they have the equal right to overcome this issue, and they have the equal right to tease these women by passing on different comments that you are not able to give birth to a child, and you are not lucky enough, and this kind of comments. So when we look at the social cultural factors, we should not ignore this social intrusion and inquisition that is very painful for women who are suffering from these problems. Thank you.
Thank you. And I think this very nicely takes us to in our discussion as to, yes, we understand these issues. Yes, we know that people, either they're not allowed to, or they feel families feel that they have the control. But what can we do to change things? So the way forward is, how can we collectively think of taking, along with having solutions for the different domains that we are working on, and keeping in mind that we have this fantastic opportunity to develop a strategy an implementation plan where there will be an opportunity where it can be implemented within health systems. So we'll have support. And I'll ask Nusrat if you could kindly, very briefly, just steer the direction of the way forward so that the next 20 minutes we can be very useful in compiling something for when we next meet in 3 or 4 months.
Okay. I think the background Naseem explained is that we met on 12th of March, and that was the beginning of our journey. And this is the follow-up. What we are wanting is to look at what evidence we have right now in Pakistan, what research can be done in Pakistan to bring positive change, because that is going to be relevant to us. And so what the plan is that we'll meet again in February in about 3 to 4 months time. And we would but continue to work between now and the next meeting through emails, through one-to-one contacts. And then the idea is to meet again in the summer around June. And then we plan to present this to the Parliament on the World Mental Health Day in October. The mental health policy and the implementation plan. So this is an ongoing work. The systematic reviews are the start of what evidence we can find. And then we would start looking at what other examples are there in other countries, in both high-income countries and low and middle-income countries. One of the things we are wanting to is align it with the Sustainable Development Goals. Because as it was mentioned, that at least 12 goals, there's enough evidence that mental health plays a significant role. And other evidence for other goals is developing. So it is a path which the government also wants to go forward in. And it's an opportunity for us as mental health professionals to bring a change. So when we talk about water, or we talk about flooding and other those bits, I think it's a lot to do with mental health. And we need to look at, we have, in Pakistan, we do have like limited psychiatrists, but we have a large number of thousands of master's level psychologists. So it's not about those human resources. When we talk about the money, we are not a low income country. We are a lower middle income country. Money is an issue, particularly when we look at the COVID-19 and the post impact. We are concerned about it in the UK. Obviously, it would have more of an impact in Pakistan. But we should keep in mind that there is no excuse that we have such high stillbirths in Pakistan. There's no excuse that we have such high neonatal mortality rate. There's no excuse that there's interpersonal violence. So these are no excuses for, and we would need to look at, we need to reflect what is individually within us. The other thing I wanted to talk or mention is that we need to look at, we cannot work with women in isolation. They're part of a family, and the man has a major role to play. We need to look at, these are joint decision making. The woman in herself cannot take the decisions. So when we start to look at preconception work, the preconception work has to start with both mothers and fathers, potential mothers and fathers. Naseem has not mentioned, we have recently being awarded a grant, large project by funded by the National Institute of Health Research and through Grand Challenges Canada. It's a large trial on parental mental health. We'd be working with about 2,000 fathers in Karachi and 2,000 mothers in Karachi. A huge, large project, and we would be training 5,000 health workers across the country. I think when Dr. Unaza, you mentioned about Karachi, that would be an opportunity that we would be working with such a large population of Karachi is nearly equivalent to the population of whole Canada. And that is how we can work with the and engage with all the different stakeholders. So I wanted to say, if we start to think about what things we can go forward with between now and February, we'll try and set up a date of a similar meeting in the next few months and look at the results. We would have, hopefully, the whole articles would have been reviewed and we would be able to present the results more. Yeah, from the other comments.
Thank you, Nusrat. So you've given us an idea, and I think this group is a part. They are co-authors, or co-authorship in terms of working towards this goal, working towards this plan. So it'll be very important to hear if people have any other suggestions besides what sort of you've put on the table as to how else can we improve, work better, collaborate better. And I think there are lots of comments that are coming on the chat, which is excellent. We'll go through them later. But if right now anybody has any suggestions, anything in terms of moving forward. Tracy, yeah.
Hi. So I think we've started some really exciting work, haven't we? And I think the stillbirth has come up quite a few times, and I think we've got an opportunity by understanding women's and families' experiences in Pakistan to build on the work we've done in high-income countries and increasingly in sub-Saharan Africa, and bring all that work together. And I think there are some very low-cost interventions that could be developed and because of the numbers of stillbirths, and particularly in the Pakistan context and the amount of morbidity, psychological morbidity resulting from those, there are some low-cost things we could do that could have huge impact, I think, on preventing a lot of more severe mental health issues. So I'm hoping we can continue our collaborations and look for funding, and we can also use our links to sort of have some really good south to south, so learn both from sort of the South Asian context and the African context and the UK context, and bring it all together, and we'll be much stronger.
That's excellent, Tracy. That's brilliant. And like Nusrat was saying, we do have to look at other countries, high and low, as to what have they done in terms of for evidence-based interventions. And you're suggesting that you're already involved with Africa and some low-cost interventions. And we are starting one, and in fact, we've started one in Pakistan with yourselves. So yes, thank you.
I mean, what we do know, just quickly to say, is that my biggest learning from starting to work in global health is that experiences are very common.
Oh, are they common?
Very common experiences, but the experiences are common. The context is different.
Thank you, Tracy. Thank you. Anybody else? Anyone else with ideas, suggestions? Guys, we are moving forward. So it's about...
I have got one, if you have got 1 minute for me, yes, please. I wrote in the chat as well. What I think is very, very important, especially if we look into our culture, is the gender issue. The mothers, if they have got lots of girls, until they have a boy, they will be having the kids, and they get more depressed because of that as well. So if we do a survey, and if we see that is the depression rate more because of the gender, so that as well we can work on to see that what is the reason for that they keep on having the kids that till they have a boy, and if they have got 4, 5, 6 boys, they keep on trying to have a girl. So this is another big issue which I see around as well, and that is more in, I think, South Asian as well. If you look in India, Bangladesh, South Sri Lanka as well, the gender issue is there a lot.
Thank you, Akshay.
Thank you so much.
Dr. Shaida?
Yes, thank you. I want to add two comments in the last moment. The first is when we talk about health issues of women in Pakistan, we should keep in mind that we are dealing with three major socioeconomic status: poor, middle, and affluent or elite socioeconomic status. So we cannot generalize our discussion, or we cannot generalize our suggestions on all the women belonging to different socioeconomic status. So being a qualitative researcher, I would recommend, as you people, you are working on a very larger scale projects. We as university teachers, we have very limited resources and we cannot conduct this type of projects. So if you take up this type of projects, please try to maintain the homogeneity of the sample while you are conducting qualitative research, so that we can come up with or we can bring some kind of results which are particularly related to some particular socioeconomic status. So we should devise our policies for women from poor families, from middle families, and from affluent families separately, because all three socioeconomic status, they have their own issues and challenges. The second important thing, as Dr. Naseem was sharing after my comments in the last presentation, that what we can do to stop this social inquisition and social intrusion in the life of these women. The very first thing or very significant thing that happens when women go through some kind of health issues or gynecological issues, that is lowering the social rank of these women. Because once a woman experiences miscarriage or repeated miscarriages, she loses her social rank. And social rank contains two very important things: social status and assertiveness. So if we give assertiveness training to these women to maintain their dignity as a woman, I think we can better handle this situation. So if women is assertive enough, and if someone want to intrude in her life, and that woman is assertive enough and she can handle the situation, and she can give shut up call that to that person that this is my life, I can better decide what to do and how to do. I think instead of weeping in isolation, that women will be better able to handle the situation where it happens. Thank you very much.
Thank you, Dr. Shaida. Thank you for your brief.
Last comment. I think we are forgetting. Yes, this is the last comment.
Yeah, please. Do.
Please. Yes, ma'am. What are you saying?
Yeah. Please do.
मैं ये कह रही थी कि I'm listening the observation of our respected colleague, but the point is कि let's just think about Pakistani culture with patriarchy and collectivism, where everybody has the right to interfere and determine the choice of women. Do you think it's possible that women can say, I'm just giving you, the oversight of southern Punjab? I think the whole responsibility of male sees that how to control women. And if that woman is a working woman, the whole pressure is how to control her, all her wishes, all her choices, all her priorities. I think it's, until and unless we check out this socio-cultural normative, style of Pakistan, this is very difficult to, come up with interventions. I think we need to consider this socio-cultural pattern kind of thing, and re-socialization, new stories, dramas could be, one thing that we can use in order to create new reality. Thank you very much.
Thank you very much. We've got 1 or 2 minutes, and coming on to stories, I just want, we've got with us Nasir Abbas. He's editor of a newspaper. Just very briefly, any thoughts that he has in terms of how do we move forward? You've heard what people are expressing in terms of the difficulties, the challenges that we have working with women in Pakistan. Nasir Abbas, 1 or 2 suggestions from yourself?
Ma'am, I think Mr. Nasir has left.
Okay.
We have one final comment from Ms. Shaida. She is community worker. If we have a minute.
Yes, a last comment from Shaida.
Bilal.
That's fantastic.
Assalamu alaikum. Assalamu alaikum.
Walaikum assalam.
मैं कम्युनिटी वर्कर हूँ, मेरा नाम शायदा कौसर है। मैं काफ़ी अरसे से कम्युनिटी में काम कर रही हूँ। कम्युनिटी का अल्लाह का लाख लाख शुक्र है कि कम्युनिटी का मुझे इतना तजर्बा हो गया है कि आप किसी भी अनजान कम्युनिटी में आप मुझे भेज दें और उनमें हर घर में जाके मैं उन लोगों को एडजस्ट करती हूँ कि वो कितने डिप्रेशन है या कितने मेंटल हेल्थ में उनको जरूरत है या कोई भी ऐसा हादसा हुआ है जिसकी वजह से वो अपने जहन में वो चीजें लेके बैठ जाते हैं। अब एक मिसाल है कि अगर हम सुसाइड वाले हैं जो अगर 12 साल से 18 साल तक के बच्चे सुसाइड कर रहे हैं, तो आज सिर्फ हम लोग जो है ना सिर्फ सुसाइड करने वाले को बुला के हम इंटरवेंशन देते हैं। मैं ये चाहती हूँ कि उनकी पूरी फैमिली को एक एक करके बुलाए या पूरे सबको एक जगह बिठा के उनसे पूछे कि ये किस तरह ये सुसाइड कर रहे हैं या ये डिप्रेशन में है, या उनकी फैमिली से भी हम लोग जरा ताबुन रखेंगे, कांटेक्ट रखेंगे ताकि हम लोगों को पता चले कि कहाँ से इनके जहनों में ये चीजें आ रही हैं या ये कहाँ से ये डिप्रेशन में है।
Thank you, Shaida Baji. Shaida Baji, she's a community worker. She's been working with us for a number of years and she has very strong links and is very dedicated and committed to the cause. So thank you, Shaida Baji. Tayyiba, do we have time for Nusrat to do thank yous and conclude?
We have last 2 minutes for final comments and vote of thanks.
Okay. Over to you, Nusrat.
Excellent organization as always. I would like to thank Professor Naseem Chaudhary, Professor Ziaul Haq, Dr. Nasir Iqbal, and all the panelists from outside Pakistan and from Pakistan. And we are so grateful for that you have joined us in this journey. I think Pakistan and the team should take great pride in this. I'm not aware of any other example across the globe that a member of the parliament is working so closely with a group for months and months to be able to develop a mental health policy along with service users and carer and an implementation plan. So great work and well done. And thank you very much for the meeting today. We hope to meet again in hopefully spring next year. And Khudafiz and Assalamu alaikum.
Thank you, everybody. Thank you so much. So we'll keep in touch, emails, and then we'll meet up. Goodbye. Have a great day.
Bye-bye. Khudafiz.
Khudafiz.